Hello, and thank you for joining us today for our webinar, Reducing Opioid Risk with SBIRT. It's presented by the big initiatives, the National SBIRT ATTC, NORC, and NADAC. Today, I'm your web facilitator, Tracy McPherson, with NORC at the University of Chicago, and I will be moderating the session today. The session today is produced in partnership by all of the organizations I just mentioned, and I hope you will take advantage of our other webinars that we have, and we'll show you some links to those right now. Thank you. Today, our webinar series is focused on opioid risk, but you can see we have a lot of upcoming hot topics around tobacco, depression, and trauma and other concerns. The materials today can be accessed from our website, the PowerPoint slides, the recording, and you'll be receiving free CEs. There are also additional resources available on our hospitalsbirtwebs.com website. We'll be offering 1.5 free CEs today, and at the end you'll be asked to complete a quick quiz, and we are approved by NADAC, NASW, NBCC, and accredited by the American Probation and Parole Association, as well as accepted by OASIS. You'll be able to ask questions later today using our Ask Questions feature on your control panel. Just type in your questions there, and at the end, I'll be moderating this session, and feel free to offer questions throughout the session or wait to the end. We'll just be keeping a running tally, and we'll answer as many as we possibly can. In the background today is technical facilitator Misty Story of NADAC. She'll be handling some of the all of the technical aspects today. And if you have any concerns about technical issues, just put them in the chat box, and she'll be able to help you or try to assist you as best as she can. Our presenter today, we have two presenters. We have Ann Bostic and Jim Matney. Ann is going to be starting us off today. She's an advanced practice registered nurse who specializes in nurse anesthesia services. She has a passionate interest in reducing the burden of substance abuse by expanding SBIRT services to a growing population of individuals at risk for prescription drug abuse. Ann has developed and presented substance abuse prevention education for nurses and has introduced more than 2,000 nurses to SBIRT. Ann has been a registered nurse for 30 years and has practiced in the specialty of nurse anesthesia for the past 17. She completed her nursing education at the University of Charleston and completed advanced training in nurse anesthesia in 1997. She is presently completing the final phase of her doctoral program at Rocky Mountain University of Health Professions, where the focus of her research is substance abuse prevention. So it's my pleasure today to open it up and to welcome Ann Bostic, our first presenter. Ann? Over to you.
Thank you so much, Tracy. It's a pleasure to be here. I really appreciate the opportunity to present on this topic of reducing opioid risk with SBIRT. I think it's really important, not only for healthcare providers, but for anyone who works with pain patients or patients at risk for addiction. So before I get started, I just want to disclose that I'm not a behavioral health professional, but as Tracy said, I am an advanced practice nurse. My specialty is anesthesia, and I've provided direct care to patients for more than 30 years. So I'm very familiar with the health consequences that can result from addiction, and also the consequences that can result from not properly treating patients when they're suffering in pain. I believe that one of the greatest challenges we face in healthcare today is figuring out how to manage pain for the millions of people in the United States who struggle with it. There's more than 100 million people in the United States who suffer with chronic pain. So we're faced with this challenge of trying to help reduce the burden of pain, while at the same time trying to help patients avoid the serious and sometimes deadly consequences of addiction. SBIRT is a strategy that I believe is critical in pain care management, especially as we move forward and really begin to change the standard of care for pain management. This prescription drug overdose epidemic that we're facing in the United States has really driven us toward creating a pain care system that demands more responsible opioid prescribing. So there are 4 objectives that we'll aim for today. The first, we'll discuss 2 major competing responsibilities of clinicians who prescribe opioid medication. We'll describe the value of a universal precautions approach as it applies to reducing opioid risk. We'll examine SBIRT as a proactive risk reduction early intervention strategy, and we'll compare screening tools for ongoing assessment of patient risk through a case scenario. But I think it's really important to start by taking a brief look at the problem of prescription drug abuse as it exists today. It really is a drug problem unlike anything that we've ever faced, because opioid pain medication does have a useful purpose in managing pain. And we really can't just stop allowing patients to have access to a medication that works so well to relieve pain. But we also have to take responsibility for the potential dangers in prescribing opioid medication and really find a way to balance the risks and the benefits. Prescription drug abuse has now become the fastest growing drug problem in America. The Center for Disease Control in 2011 announced that prescription drug overdose is an epidemic in this country. It's become one of the major causes of accidental death, second only to motor vehicle accidents. And in some states, it exceeds motor vehicle accidents as the leading cause of accidental death. So clearly there's a need for urgent action to reverse this trend. There are a number, as far as health consequences, there are a number of health consequences that are directly related to prescription drug abuse, including the risk of transitioning to IV use, which puts a person more at risk for communicable diseases such as HIV and hepatitis C. And other health risks include falls and fractures that are common in elderly patients who are taking opioid pain medication, and neonatal opioid withdrawal, as we've seen huge increases in the number of babies being born addicted to opioids, and that in and of itself is a whole nother problem. The healthcare costs associated with prescription drug abuse are astounding. It contributes to increased emergency department visits, physician visits. There's so many costs related to fraud and abuse, and the societal costs are also extraordinary. Prescription drug abuse contributes to increased crime, increased employment costs, disabilities, and this problem of prescription drug abuse has grown exponentially in just a little over a decade. So there's really an urgent need to take action to turn this trend around. And I think this country is answering the call to action. We're devoting tremendous resources to this effort of reducing opioid risk so patients can still receive adequate pain care with less risk of serious adverse consequences. So for healthcare providers, taking action really requires us to effectively manage 2 competing responsibilities: helping patients reduce pain while at the same time avoiding addiction and other adverse effects of powerful opioid medication. In 2010, there was a study by Dunn and colleagues that revealed that many overdose deaths could have been averted by simple changes in prescribing practices. And since that time, much of the effort toward reducing opioid risk has focused on providers, people who prescribe opioid medication. Research has shown that providers do not receive adequate education in pain management or addiction risk, and this has contributed greatly to the prescription drug problem. Pain is one of the most common reasons that individuals seek medical care, and over the past 2 decades, there's been a heightened focus on addressing pain with patients and showing that they are receiving adequate pain relief. And this has led to much more lenient opioid prescribing practices and to an increased demand for opioid medication. Opioid prescriptions nearly quadrupled in 1 decade, and with that, overdose deaths also quadrupled. So for healthcare in this coming decade, I really believe this will be our greatest challenge: finding a way to balance these competing responsibilities. But with all the initiatives that are underway right now, I really believe we will reverse this trend in the coming decade. I believe pain care will evolve over the next decade, and it will look completely different 10 years from now than what it looks like today. And I think it's beneficial to look at pain care as it's evolved over the past decade or so, because taking a look back in time, we can see that the evolution of pain care over the past decade, with the drastic increase in the use of opioids, has greatly contributed to the prescription drug abuse epidemic we're facing today. And the efforts that we make today in reducing opioid risk will determine what pain care and prevention of addiction evolve to in the coming decades. In the 1990s, opioid medication was not a first-line treatment for pain. I remember working in the emergency department in the 1990s, and at that time, opioids were prescribed very cautiously. They really weren't utilized much, except in cases of severe pain or when patients had an acute injury or trauma. But growing concerns in the 1990s that really were mostly around cancer patients who weren't receiving adequate pain relief. There were a lot of growing concerns at that time that patients weren't receiving adequate pain relief. And this fueled a massive campaign to improve pain care. And with that initiative, organizations such as Joint Commission, which was called JCAHO back then, the World Health Organization, professional associations, and many others really started advocating for expanding pain care. And I think one of the biggest shifts in healthcare occurred in 2001 when the Joint Commission came out with a statement that came to be known as the pain standard. And it encouraged physicians to probe for pain and intervene. And if physicians could not show that they were assessing, treating, and reducing pain for patients back then, they faced poor quality ratings within their organizations. And healthcare organizations even faced the risk of poor quality ratings because of this pain standard. So you can see how this really fueled the fire for an increase in opioid prescribing. Now, 10 years later, in 2011, prescription drug abuse takes the lead as the fastest growing drug problem in America, and the Center for Disease Control says that prescription drug overdose is an epidemic in this country. So then in 2014, we're now spending millions and millions of dollars and devoting tremendous amount of resources trying to clean up the mess and reverse this trend. The pain standard I was referring to that Joint Commission is credited with from their statements in 2001 is now evolving again, because in 2012 Joint Commission issued another very important statement. Due to significant increases in adverse events and deaths related to opioid medication in hospitals, Joint Commission has now issued a Sentinel event alert. And instead of just focusing on the need to address pain issues, the Sentinel event alert calls for reducing opioid risk. So just as the pain standard in 2001 really influenced the management of pain in hospitals and other healthcare settings, I think this Sentinel event alert in 2012 will also shape pain care for the coming decade and encourage more responsible opioid prescribing. I have the Sentinel event alert in front of me, and I think it's really interesting because on page 3, where it talks about appropriate education and training, it says that clinicians who prescribe pain medication need to be advised to use both pharmacologic and non-pharmacologic alternatives, including multimodal adjunct therapies such as physical therapy, acupuncture, massage, ice, music therapy, non-narcotic analgesics such as acetaminophen, non-steroidal anti-inflammatory agents, and muscle relaxants can be used first before prescribing opioids. And in addition, when used in combination with opioids, these non-narcotics may reduce the dose of opioids required to effectively manage pain. So it's really interesting to see how this Joint Commission, the statements that come out from Joint Commission, will evolve pain care in the coming decade with this new Sentinel event alert. I also think it's interesting when we look at chronic pain and how it's evolved over the past 2 decades. Chronic pain affects more than 100 million people in the United States. It costs our nation more than $635 billion a year, and it's a serious public health concern. At the same time, we have this other public health concern of addiction, and in particular addiction to prescription drugs, that seems to mirror the chronic pain problem. So I want to talk for just a few minutes about pain. I remember having it drilled in me as a young nurse. Patients can't get addicted to pain medicine if they're truly experiencing pain. We used to tell our patients that whenever patients express concerns about possibly getting addicted. Today, we know this is not true, and there's a lot more that we know about addiction and about pain that we didn't know back in the 1990s. So let's talk for just a few minutes about pain. The International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. There are different categories of pain, and it's important to understand that pain, depending on whether it's acute pain or chronic pain, responds differently to opioid medication. Acute pain responds well to opioid medication. Acute pain is caused by disease, by inflammation or injury to tissue. It generally comes on suddenly, and usually it subsides once the tissue damage has healed. Chronic pain, on the other hand, does not generally respond as well to treatment with opioids. Chronic pain persists over a long period of time and is often resistant to most medical treatments. With chronic pain, the pain signals continue beyond the original tissue damage. It's like the pain system gets turned on and can't seem to be turned off. It can be made much worse by environmental and psychological factors. And so chronic pain and acute pain are very different, and what works to treat acute pain may actually be counterproductive in treating chronic pain. There actually is a lot of controversy about the place for opioids in the management of chronic pain, and since opioids for chronic pain are prescribed over a long period of time, it makes sense that the risk for addiction would increase when patients with chronic pain are prescribed opioids. So we live in an era where chronic pain and addiction are both serious public health problems, and both are now classified as chronic diseases for which there is no known cure. Both are influenced by emotional, cognitive, and psychosocial factors, and comorbid psychopathology often exists with both of these conditions. Chronic pain typically erodes a person's life, their physical activity, their concentration, their emotional stability, their interpersonal relationships, their sleep patterns, and so does addiction. Both conditions over time lead to problems at work, at home. Both can lead to depression, anxiety, insomnia, and even suicide. So in managing chronic pain, just as in managing addiction, healthcare providers are faced with a condition that is complex and multifaceted. The fact that pain is influenced by emotional, cognitive, and psychosocial factors, including depression, anxiety, and insomnia, makes dealing with it very complicated. Then when you add the comorbid psychopathology that often exists, such as depression, personality disorders, and substance use disorders, it really becomes a complex problem. And chronic pain and addiction are both complex problems that seem somehow intertwined, entangled together. And prescription opioid abuse seems to be what's caused them to merge into this dual public health crisis that we're facing. The 2011 Institute of Medicine report said that a cultural transformation is needed to better prevent, assess, treat, and understand pain. In order for this to occur, there must be a shift in our approach to pain care. We need an integrated and multidisciplinary approach where primary care physicians, behavioral health specialists, and pain care specialists work together to help relieve pain and help patients learn to self-manage so that they don't have to depend on opioids as their primary treatment for pain. Clinicians need to help motivate patients toward healthy behavior and alternative pain modalities so patients never use prescription drugs in a manner that puts them at risk for addiction or for overdose. Healthcare providers, they come face-to-face with patients every day in physician offices, in clinics, in emergency departments, and when patients are experiencing health issues related to substance abuse, clinicians have an opportunity to help them. But more often than not, clinicians lack the skills and the expertise to address the problem in a manner that will encourage behavior change. So they frequently just avoid discussing the problem of substance use at all, and then they miss this window of opportunity for preventing adverse outcomes. But there are a lot of efforts underway now to facilitate this cultural shift in pain care, like what the IOM refers to. Federal and state government organizations are working together to help reduce opioid risk. We're investing millions and millions of dollars in a tremendous amount of resources. Complex surveillance systems are being developed to help better understand and get control of the prescription drug abuse problem. Legislation is being passed both at the federal and state level. Manufacturers of opioid medication are being required to provide patient and provider education about the risk of opioid use. Physicians, nurses, and other prescribers are being mandated to obtain education about risk. In West Virginia, we just recently passed legislation that requires all healthcare providers who prescribe, dispense, or administer controlled substances to obtain continuing education. Stricter laws are being adopted. Pill mills are being shut down. Internet pharmacies are being prosecuted, and doctor shopping's becoming much more difficult. So there's a lot of initiatives underway right now. Manufacturers, suppliers, and healthcare organizations are all taking steps to try to reverse this prescription drug problem. Manufacturers are developing abuse deterrent formulas, and in July 2012, the Food and Drug Administration released what is called the Risk Evaluation and Mitigation Strategy for long-acting opioids. And this requires manufacturers to provide education to the public about the risks when taking opioid medication, particularly long-acting opioids. And then a blueprint for provider education was published, and manufacturers are also being required to take some responsibility in making sure that clinicians who prescribe opioid medication are also educated about how to avoid adverse consequences. Healthcare organizations and physician practices are starting to utilize prescription drug monitoring programs much more frequently, and they're implementing policies such as the universal precautions policy for more responsible opioid prescribing. So this is where I want to begin to talk a little about SBIRT and the role SBIRT can play in reducing opioid risk. I expect most people who are listening to this webinar are somewhat familiar with SBIRT, but I want to briefly review what it is in case there's anyone not familiar with it. Jim Matney, our clinical director, our SBIRT clinical director, will be presenting the second part of the webinar, and he'll be going into a lot more detail about how SBIRT works and how it can be effective to reduce opioid risks. But I just want to make sure everyone has some familiarity. So SBIRT is a comprehensive prevention strategy that aims to help people become more aware of how risky substance use may be impacting their life and their health. It aims to motivate patients to begin the process of change through brief conversations that are supportive and non-confrontational. SBIRT was developed as a public health model, and there's now years of research supporting SBIRT. as a model for reducing risky substance use. And there's strong research showing evidence that it helps reduce alcohol, tobacco, and other drug use. So it's an evidence-based model that really has a tremendous research base behind it. It has 3 components: screening, brief intervention, and referral to treatment, and Jim will be talking a little bit more about those components. But I believe the SBIRT model is key to reversing this prescription drug abuse trend in the United States. It can help us balance the risk with the benefits of opioid prescribing, and it can help us achieve better patient outcomes. Because responsible opioid prescribing, it's not aimed to deny even high-risk patients treatment with opioid medication, but rather it aims to establish a level of monitoring that will balance opioid risks with the benefits. The SBIRT model is an evidence-based prevention model that fits perfectly in pain care as a model to reduce opioid risk. SBIRT makes sense in pain care because it can help move us toward not only making clinicians more responsible for appropriate prescribing, but also it can help us make patients more responsible to take charge of their own health and wellness. SBIRT also fits well in the universal precaution approach to pain care that's really gaining widespread acceptance in healthcare. The term universal precautions in pain care refers to a standardized approach for the assessment and ongoing management of all patients who receive opioid medication for long-term pain care. The concept of universal precautions was borrowed from the infectious disease model, and it recognizes that any patient in pain who receives opioid medication may develop a prescription drug problem, just like any patient who needs an IV or blood drawn could potentially have and spread life-threatening diseases such as HIV. Universal precautions with infectious disease led us to prevent the spread of HIV and hepatitis C by having minimum standard precautions that were used with all patients. And the same holds true with pain care. The problems that have developed from the misuse of prescription drugs makes it clear that since there is no sure way to predict which patients will misuse prescription drugs, the safest and most reasonable approach to prevent potentially life-threatening consequences is to apply a minimum level of precaution for all patients. And that means screening all patients for risk factors, developing treatment plans based on that level of risk, and referring them as needed. A universal approach, precautions approach for all patients receiving opioids can really help reduce risk for prescription drug abuse. It can help reduce stigma, and it can help provide better continuity of care. Hospitals, physician offices, clinics, and other practices are really moving toward this universal precautions approach to help balance the risk and benefits of opioid medication. It's an approach that healthcare providers can relate to because it's similar to the universal precautions approach that's used with infectious disease. And it makes sense to implement a minimum level of precaution with all patients who receive opioids. But I think we can do all these things. We can screen our patients, develop pain care treatment plans, do ongoing monitoring and refer patients, and still not achieve the outcomes that we aim to achieve. And that is to motivate patients towards self-management and provide tools that will help the patient either never engage in risky use of prescription opioids, or if they're already using opioids in a manner that's risky, motivate them to reduce the use of opioids to a less risky level. And this requires motivating patients to change their behavior. Most healthcare practitioners lack the skills and training to help facilitate behavior change. So, as we spend millions of dollars developing strategies to reduce opioid risk, I think we really need to focus more attention on helping providers gain the skills needed to facilitate behavior change. And SBIRT is a model that providers need. They need to learn in order to help facilitate behavior change. We can teach providers how to screen patients and how to develop treatment plans, but if we don't teach them how to have the conversation with patients about substance use, we will never achieve the patient-centered outcomes we expect. Providers must learn to motivate at-risk patients to behave in a healthy manner in order to help prevent patients from ever using prescription drugs inappropriately. And I guess part of the reason we haven't focused as much attention on actually teaching providers to have the conversation with patients about their substance use is because there's a number of barriers that make it difficult. Limited time, the patient-provider interactions are getting shorter and shorter, and there's always competing healthcare issues. Also, providers often avoid the subject of substance use with patients, maybe because they lack knowledge or maybe because they're just uncomfortable talking to patients about substance use. Providers often really don't know how to have a conversation that will facilitate behavior change. So again, they just avoid the conversation and in many cases miss an opportunity to help those patients who are at risk. We really must put more attention on helping physicians, nurses, and other healthcare providers have the conversation with patients about risky substance use, because teaching providers the SBIRT model really can help us overcome these barriers. In 2013, the Department of Health and Human Services published a report on addressing the prescription drug problem in America, and that report outlined key initiatives that are underway to address the problem. 8 key initiatives were discussed, and they're listed here. I'm not going to go over all of those because I'm starting to get a little short on time, but it's evident that we really are literally investing millions of dollars toward cleaning up this problem. But despite all these efforts, if we don't train providers to have the conversation with patients about their substance use in a manner that can facilitate behavior change, we're ignoring a huge opportunity. Healthcare providers have opportunities with patients every day, with every interaction. So if we're to achieve patient-centered outcomes in our efforts to reduce opioid risk, clinicians must become better educated about substance use disorder. We must be willing to talk to patients about their risk and their patterns of prescription drug use, and we must have the skills to facilitate behavior change. Only then will we really be able to help patients self-manage and move toward healthy behaviors that reduce their risk of ever using prescriptions inappropriately or in a risky manner. During physician office visits, during clinic visits, emergency department visits, healthcare providers come face to face with risky substance use all the time and in all these settings, and we have to recognize the opportunities that are before us to help patients. So again, there are a number of initiatives that are guiding us in our efforts to reduce opioid risk: the universal precautions approach, the risk evaluation and mitigation strategies, the Joint Commission guidelines. All of these things are aimed at reducing opioid risk, and all of them call for screening to assess patient risk, developing a plan of care that's based on that risk, educating patients about proper use and potential adverse effects of opioids. And SBIRT is all of these things in a nutshell, plus so much more. SBIRT places a high importance on how to have the conversation with patients to facilitate behavior change. And I believe this is critical if we want to achieve patient-centered outcomes. So much of our efforts today are focused on providers. The provider needs to screen, the provider needs to document treatment plans. But first and foremost, we have to remember that providers need to be willing to have the conversation with patients about substance use. They need to do it during regular health visits, they need to do it consistently, and they need to do it in a manner that's non-threatening and supportive. Teaching providers how to do this is really important, and they need to understand why it's so important. So I really believe that we need to focus much more attention on teaching providers this skill. So this last slide, I just want to sum up the important points I've tried to make. First, that prescription drug abuse is an epidemic in this country, and it's a serious public health concern. Chronic pain is also an epidemic and a serious public health concern. Both are costing our nation billions of dollars, and both are contributing to the healthcare crisis we face in this country, and both are weighing heavily on society as a whole. So dealing with these public health issues is critical to the health of our country, and one of the biggest challenges facing healthcare today, I think is one of the biggest challenges facing healthcare today. And prevention efforts are key. Research has shown that the most effective drug abuse prevention programs are those that help individuals develop intentions and skills to act in a healthy manner, and those that create an environment that supports healthy behavior. SBIRT is an evidence-based prevention model that's been proven to help reduce risky substance use, and it can be used to help us in our efforts to reduce opioid risk so that we can get this prescription drug epidemic turned around. SBIRT's a proactive risk reduction model that can help us effectively manage pain for the millions of Americans who suffer from chronic pain, and it can also help us avoid the serious and sometimes deadly adverse effects of opioid medication. Thank you very much.
Thank you, Anne, and thank you for sharing that terrific information and education with us today. And I can hear your passion and the years of experience and knowledge that you've gained in your real-world practice and in your training coming through. And so thank you so much. That really was terrific. And now it's my pleasure to introduce Jim Matney. Jim is the director of the Screening, Brief Intervention, and Referral to Treatment grant in West Virginia. He has spent more than 23 years working with the addicted population. His background involves development and implementation of programs for adults and youth designed to address the many issues associated with substance misuse, abuse, and addiction. Jim has also an extensive background in the treatment of mental health, trauma, and family issues. And he also has an extensive background in the administration and program development and compliance and training. So it's my pleasure to welcome Jim. Jim, I'm going to turn it over to you.
Thank you, and it's a pleasure to be here with you today and speak to each of you about this very important topic. I spent the last 5 years managing the SBIRT grant here in West Virginia. Most of my career before moving to West Virginia was spent with the deeply addicted population. And I often ask myself throughout my career why we allow people to become so sick. And probably many of you are familiar with the saying that people have to hit rock bottom. Well, SBIRT is a testament that we really don't have to allow people to become so very sick before we intervene with them. And so it's my pleasure to talk about how the SBIRT model can be used to mitigate the risks associated with the treatment of pain. If you look here, those of you who are familiar with SBIRT will probably have seen this graphic before. Those of you who are not as familiar with SBIRT, this is the graphic that we often use that exemplifies the conceptual basis of SBIRT. We know if we look at the general population that approximately 70% of the general population in terms of substance misuse are low risk or abstinent. If we look at the top of the pyramid, approximately 5% of the general population have crossed over into addiction. This is approximately 20 million people nationally. In the middle of the pyramid in the yellow cautionary area, we know there are many, many people that fly under the radar who are engaged in risky or harmful substance use. With these individuals, they will either cross over into addiction and enter the red area, or in some cases they will go back down to low risk or abstinent. With the SBIRT approach and with this population, we want to make sure that we monitor risky or harmful behavior and intervene early before patients cross over into addiction, where their disease process is much resistant to intervention. These are the components of the SBIRT model. There are 5 basic components of screening, brief intervention, and referral to treatment. And in my teachings with people, I always point out that we have to do each of these stages. And we know with many evidence-based approaches that often fidelity is an issue when we implement these approaches. So if we leave out the motivational enhancement part of the SBIRT model, or if we leave out the follow-up and the self-monitoring part of the SBIRT model, we lose the integrity of the models. Therefore, I strictly tell people that it's important to monitor fidelity in how this model is implemented. We're going to go through each of these phases, and then we're going to look at a case study that will help you with a case scenario that can help you in your work with real patients. During the screening phase of the SBIRT model, these are the assessment instruments that we are recommending that you use with patients who are being treated for pain management. If you look at the top, you see the ASSIST instrument. The ASSIST instrument measures alcohol and drug use and was developed by the World Health Organization some time ago. It has 7 questions, including a drug injection question, and it assigns a level of risk based on a score. The ASSIST instrument is really does really well with people who don't have a lot of background and training in addiction, and it gives them a level of risk based on a score, just like we would with blood pressure or cholesterol or other screening procedures. The second questionnaire there is the Physical Health Questionnaire. And the Physical Health Questionnaire, or the PHQ-9, measures depression. And we always want to measure depression when we're assessing for addiction risk, because we know depression is the #1 co-occurring mental health issue that often is seen with those who are misusing substances or who are addicted. Again, the questionnaire was developed to fit very well into medical settings. It's very brief. It has 9 questions, and again, it determines the level of depression based on a score, and it gives recommendations on scores that can be followed by the medical professional. The next assessment instrument is the opioid risk tool, and the 4th instrument is the screener and opioid assessment for patient with pain, or the SOAP. We are not recommending that you have to administer each of these in your patients that are being treated for pain. The opioid risk tool with 5 items is preferable to the SOAP in low-risk patients. So if you have a patient who scores low on the ASSIST instrument for addiction, low on the PHQ-9 for depression, this instrument is more appropriate because it will pick up low-risk indicators of patients who are at risk. The next instrument, the SOAP instrument, has 14 questions, and if the patient scores higher on the ASSIST or higher on the PHQ-9, this instrument is more appropriate to evaluate risk with these patients and has been validated to pick up more indicators in terms of risk. So you can base which instrument that you want to use based on the patient's risk level on the first 2 instruments. The fifth instrument here is the COM instrument, or the current opioid misuse measure. It has 17 questions to evaluate misuse of opioid medications for chronic pain. It's easily scored. A score of 9 or above is considered a positive and an indication that the patient has crossed over and is engaging in misuse of the medication and aberrant behavior. The second phase of SBIRT is the feedback, brief intervention, education, and advise phase. During this phase of SBIRT, we want to provide results of the risk screening to the patient. We want to educate the patient about their personal level of risk compared to the general population, and we want to educate them about their risk and protective factors in regard to substance use in general. We also conduct a brief intervention during this phase and advise the patient about the need to develop personalized strategies to reduce risk. We use the ORS approach, which is part of motivational interviewing, and the FRAMES approach, again, which is part of motivational interviewing. All the people that I train, I encourage them to receive full motivational interview training before implementation of the SBIRT model. During that training, you're going to learn about the ORS and the FRAMES approaches and how to approach patients in a non-confrontational manner, making them basically the expert on their own behavior and their strategies that will work for them in order to mitigate their risk in terms of addiction. It should be noted here at the bottom of the screen that there are codes for screening, brief intervention, and referral to treatment that I'll briefly want to point out to you that will take care of some of the costs of implementing SBIRT into your practice. There are CPT codes for commercial insurance. There are Medicare codes for Medicare clients, and there are Medicaid codes. Of course, Medicare codes are national and can be billed anywhere in the United States. The Medicaid codes, as we know, have to be implemented by individualized states. So you have to find out if your state in particular have activated the codes for SBIRT before you attempt to bill this process. This phase of SBIRT is motivational enhancement and engagement, and this is critical to SBIRT. And without this, you can't really effectively do SBIRT, because SBIRT's based on where the patient is in terms of the change process and their level of motivation and their ability to engage in the process. So the purpose of motivational enhancement with SBIRT is to gauge the patient's willingness to engage in self-monitoring strategies and other strategies to manage pain and improve their functional abilities in addition to the use of the medication, making it a much better approach than a traditional approach of just using medication to treat pain. So what we want to do is we want to present this readiness ruler to patients and have them on a scale from 1 to 10 rate themselves in terms of their willingness and their ability to engage in additional strategies to manage pain in addition to the medication. If the patient scores low on this scale, we know we have to provide more support for that patient. If the patient scores higher on this scale, we know that this patient has a good start in the change process. If the patient, for example, says that there are 5 on the readiness ruler here, we never want to ask the patient why they're not at a higher number. This indicates judgment to the patient, which is counterproductive in the SBIRT process. We always want to ask the patient how they got from a lower number to the number they're at now. That gives us the ability to provide affirmations for the patient in terms of how they're moving along in the change process. In this phase of SBIRT, We want to work with the patient in the development of personalized strategies and a self-monitoring plan. We use motivational interviewing, which is based on the concept of self-efficacy and accountability. Essentially, again, we want to put the patient in the driver's seat in terms of the development of personalized strategies that they know work for them, that they may have tried before and have been proven successful for them. It puts responsibility, too, back on the patient for their own wellness and health, as opposed to the practitioner taking all the responsibility for the patient's wellness. During this phase of SBIRT, we want to use assigned consent and a treatment plan that outlines risks versus the benefits of opioid medication to treat their pain. We want the consent and the treatment plan to identify patient responsibilities during this process as well as practitioner responsibilities. And we found that signed consents and treatment plans, which should be the part of the policy of any clinic who is treating pain, these instruments really stress the importance of strict compliance in terms of level of risk as the patient moves through the process in the mitigation of their pain. And the last stage of SBIRT, critically important, follow-up and self-monitoring. We want to reevaluate the patient, their adherence to their treatment plan, and their functional abilities. Are they being able to work? Are they being able to engage in recreational activities and activities of daily living? We want to do this on every visit, particularly in the early phases of treatment with opioid medication. During these visits, we want to evaluate the presence of aberrant taking behaviors using the CALM instrument that I talked about before. We want to evaluate the patient's use of developed strategies and their adherence to their self-monitoring plan, their support mechanisms, and we want to adjust as needed. We know that often the developed strategies that patients have sometimes don't work as well as they would like them to or as well as we think they should. So we have to go back and tweak those strategies. Sometimes we have to add strategies so that the treatment plan becomes a living dynamic document that will change over the period of the patient's treatment. During this phase, we also want to evaluate on an ongoing basis the patient's need for referral to other practitioners such as behavioral health or other types of consultations such as physical therapy or perhaps a nutritionist. And we want to make those appointments for the patient and make sure that the patient has those appointments in hand before they walk out the door. And we want to inform the patient that when they go see those other practitioners for consultations, that they get signed releases that will allow us to speak to them and coordinate their care. So we put together a case study that will hopefully help you be able to apply the SBIRT model in a real-life scenario. So we have a fictional patient here by the name of Joe Smith. Joe is a 48-year-old white married male. His profession is a coal miner, and we have many of those here in West Virginia, and yes, they do have a lot of pain. Joe is a high school graduate, and his presenting complaint is back pain. He's been referred to Dr. Jacobs, a primary care clinic, who has limited experience with pain management. But the clinic that Dr. Jacobs works in is part of a pilot project for pain management. So we know there is some interest on the part of this clinic to look at evidence-based ways in order to manage pain. During visit 1 at the primary care physician's office, Joe presents to see Dr. Jacobs. He's accompanied by his wife, who has essentially insisted that Joe see Dr. Jacobs because of his pain and accompanying irritability and missed work. This has resulted in marital discord, which is exacerbated by financial problems. He's attempted to get relief by use of alcohol and over-the-counter medications, but has stated to his wife that he is, in quotes, at the end of his rope. Now, we have several risk factors here right offhand that I want to point out. Red flags are that the patient has only come to see Dr. Jacobs on the insistence of his wife. He has a level of agitation, which tells us that there are psychosocial risk factors here. He is using alcohol in order to try to deal with his pain, which tells us that there are substance abuse risk factors here as well. And then the statement that he is at the end of his rope leads us to think that there may be a red flag that Joe has some possible depression, which we know is very common both with addiction and with pain. Also, during visit 1, Dr. Jacobs assesses Joe's pain and agrees that a trial use of opiate medication is indicated. Dr. Jacob calls his colleague who has more experience with pain and who recommends the use of a risk screening tool for opioid use. Therefore, Dr. Jacob does a warm handoff to his nurse who is trained in SBIRT. Now, there's a couple things in this scenario that I really want to stress. The word trial. We always want to communicate to the patient when opioid medication is prescribed that is a trial, because we know that there will be some patients who will not be able to tolerate the opioid medication, and that eventually the risk will outweigh the benefits. Also, you see here that we talk about a warm handoff. This is critically important because we want to communicate to the patient that their pain is being treated through a team approach. So we have a nurse who's trained in SBIRT. Let me point out that SBIRT is a very can be very well trained, taught to nurses in a fairly short period of time. Generally, Ann and I have presented to many nurses in 4-hour segments, and they were able to demonstrate competency in being able to carry out this approach and implement how to have a conversation with a patient in a non-confrontational, motivating manner. So again, the warm handoff is very important. So Joe is handed off to the SBIRT nurse. The nurse completes a thorough nursing assessment. It's particularly important in terms of the nursing assessment that the assessment clearly addresses risk factors associated with addiction and substance misuse. Family history, particularly whether there is any family history, this speaks to the genetic nature of addiction. Psychiatric history, because we know that individuals who have psychiatric issues are more prone to use medications to medicate those symptoms. And then personal history of addiction, and then social functioning and family functioning, both of which are very germane to whether Joe will receive the support that he needs in order to engage in self-monitoring and to report back to his practitioner his compliance and his self-monitoring activities that are on his treatment plan. The nurse conducts screening with Joe using the opioid risk tool, the physician health questionnaire, and the assist. Now, I have these a little backwards here. What we want to do first is we want to administer the assist. The assist we want to administer first because it's going to indicate up front whether Joe is at risk for addiction and whether he's currently misusing any substances that could have some interaction with the opioid medication. Secondly, we want to do the physician health questionnaire in that order. And then thirdly, we want to administer the opiate risk tool because remember, the ORT is for individuals who are at lower risk as opposed to the SOAP, which is indicated and validated for patients who are at higher risk. And the assist and the physician health questionnaire will tell us those things. Also, during visit 1, the SBIRT nurse is going to provide feedback, do a brief intervention, which Ann and I often refer as having a conversation. And the nurse is going to advise Joe very clearly on the steps that the team feels he needs to take in order to manage his pain. She talks to him about his risk screening instruments, that his score on the opioid risk tool is 9, which puts him at a high risk. His score on the PHQ-9 is 9, which indicates moderate depressive symptomatology, and that his score on the assist is 14 on alcohol, which indicates that he is using alcohol at a risky or harmful level. It's important during this phase of the SBIRT process that the patient is informed that these risk tools are used for all the patients who come to the clinic who are being considered for opioid medication, so that the patient doesn't feel targeted by this process. Also, during this visit, the nurse conducts a brief intervention, advises Joe to abstain from alcohol use because of the interaction it could have with the opioid medication, and she provides education about the risk and protective factors that could be in play with Joe in particular, and a need for ongoing monitoring as Joe goes through the process of being treated for his pain. Also, the nurse is going to administer the readiness ruler to get an indication of Joe's level of motivation in terms of engaging in personalized strategies in order to contribute to his wellness and pain management. Also, the nurse is going to advise Joe that she feels that, and Dr. Jacobs feels that he needs a behavioral health consult to evaluate his depression, and that he needs a physical therapist consult to evaluate his need for strengthening and stretching exercises as part of the process of treating his pain. Now, let me point out here, the best case scenario here would to have a behavioral health clinician on staff and to treat Joe's pain in an integrated health setting. That's not always possible. It's happening more so as we move forward with the Affordable Care Act, but we don't have a behavioral health clinician everywhere. So it's important that the nurse makes these appointments for Joe, that he has an appointment before leaving the office in hand, both with the behavioral health clinician and the physical therapist, and the nurse then reiterates again the importance of these consults and the management of his pain. So this is what a sample initial treatment plan will look like in our scenario with Joe here. We're going to treat his pain with a trial of Lortab 3 times a day. We're going to refer him to a physical therapist to evaluate his need for strengthening and stretching exercises. Dr. Jacobs has agreed to treat Joe's pain with Prozac 20 milligrams 1 time a day. We're recommending a consultation with a behavioral clinician to evaluate his depression and his need for ongoing counseling for his depression and his level of agitation. We're going to reevaluate his pain, his functional abilities, and use of self-monitoring strategies and depression in 30 days after initiation of the opioid medication. And we're going to administer the CALM instrument every 30 days to assess for misuse or presence of aberrant behaviors. And lastly here, we're going to recommend that Joe use a web-based application called One Health, which is a social media site that will connect him with other people who are having pain or other issues in terms of behavioral health. It will allow him to participate in chats with other people that have the same kind of issues that he does, and gives him an added level of support as he's being treated for his pain. During visit 2, Joe returns to see Dr. Jacobs. He's unaccompanied by his wife during this visit. Dr. Jacobs reevaluates Joe's pain. Joe reports his pain is somewhat better, it's improved, and that he would like to continue the opioid medication. And so Dr. Jacob agrees to prescribe another 30 days of Loratab and does another warm handoff to the nurse. So we see that each time Joe comes for a visit, he's going to see the SBIRT nurse in order to review compliance with his treatment plan. The nurse reviews Joe's treatment plan compliance. She sees that he has not received his behavioral health consultation. He reported the day of his appointment he was in end quote, a lot of pain. However, he did not reschedule his appointment. That's a huge red flag. Joe did see the physical therapist. However, he was only partially compliant with the exercises that were prescribed by the physical therapist. He reports his depression is improved, his sleep is improved, he has less days he's feeling down, and he denies alcohol use. However, we have no corroborating way to substantiate actually whether he is using alcohol or not during this visit. Joe has the CALM questionnaire administered to him again by the nurse, and he scores a 10, which indicates a high risk level. So the nurse conducts a brief intervention with Joe. She has the conversation regarding the score and encourages his compliance with the treatment plan and his self-monitoring strategies. Joe leaves the office and indicates that he will try harder. Joe returns 25 days later during visit 3, requesting an early refill of his Loratab. This is a huge red flag. He states that his pain has gotten worse since his last visit. So what should come to mind immediately, since his pain is perceived to have gotten worse, is whether he has actually misused his medication, taken extra doses, perhaps, than he should have because of his perception that his pain had gotten worse. He is accompanied by his wife, who reports that he's missed several days of work, which reports that his functional abilities have decreased or not at least gotten any better, and that he continues to use alcohol several days a week. He, again, as corroborated by his wife, has intermittently doing his physical therapy exercises. Dr. Jacobs is concerned and wants Joe to see the SBIRT nurse once again before a determination to prescribe additional opioid medication. The SBIRT nurse again administers the CALM instrument, and Joe scores an 11. As you recall, his score previously was a 9. So his score has gone up on the CALM instrument, indicating there may be a level of misuse or engagement in aberrant behaviors. She reviews Joe's compliance with his treatment plan. She finds that he is significantly non-compliant with the plan, and of course she does this all within the framework of the motivational interviewing techniques in a non-confrontational manner. She does a brief intervention. She has the conversation, as we talked about before, and informs Joe that he must speak with Dr. Jacobs about his score on the CALM instrument and his lack of compliance with his treatment plan. After consulting with Dr. Jacobs, they decide to meet with Joe and inform him that his prescription for Loratab will be discontinued, and do a brief intervention with Joe where they inform him that the benefits of continued use of opioid medication is not balanced against his risk for continuing to use the medication. There are several worksheets that I wanted to point out that could be used in this scenario with Joe and other patients. This worksheet in particular could be used to identify risk factors for particular patients. You see there are psychological, behavioral, social, family, and genetic risk factors. And you see a column there where patients can record their particular risk factors. The clinic can keep a copy of this sheet, and of course Joe should take a copy with him that can be reviewed on each visit back to the clinic. Likewise, there's a sheet that we recommend for substance misuse protective factors. Any kind of stress reduction activities that Joe feels he can engage in or is engaged in before that will help him with his pain and uncomfortableness, his health and wellness, his nutritional habits, his exercise, whether he's getting adequate sleep, and then a healthy work and social environments. Also, this worksheet in particular could have another column added if you chose to do so, so that the patient could rate on a scale from 1 to 10 how they're implementing the protective factors in those particular areas. And I could see how that could be particularly helpful. Again, we have another self-monitoring worksheet during which the patient can identify their particular stress in several different life areas and how they can use their stress in order to balance against the risk factors that are particular for them. And you'll notice also at the bottom we have a ruler again on a scale from 1 to 10 for the patient to rate how helpful they felt that this particular worksheet was to them in helping manage their process. Again, another sheet on which patients can record specific actions with specific date lines, helpful people, useful thoughts, strengths that they have in order to balance risk and their particular individualized goals, possible problems, again, which refers to risk factors, and then possible solutions that would help them with those particular barriers to their care. And this is just the interface of the One Health website. It's onehealth.com. It's a free website. Anyone can log on, get a username and a password, and go check this out. And I do encourage you to do this and encourage you to use it with your patients in terms of having them have the ability to monitor their own health and wellness. These are particular resources that Ann and I felt would be helpful for each of you. There's some online training for opioid risk, REMS training, which we highly recommend, and then these are the websites for the screening tools that we've talked about today, and then other resources that talk about pain. And then on your copy of this webinar, you'll have references that we've used to put together this presentation. And then we have contact for both Ann and I. We're both available through email and phone. If you have questions that come up later that you don't want to ask now, or if you have particular situations that we may be able to help you with, feel free to email us or give us a call. And so, Tracy, I'm going to turn it back over to you for the questions section of the webinar.
Thank you. Thank you so much. What a terrific presentation today. Thank you so much for this wonderful education and all of the experiences you've shared. And I love the cases to help walk us through the process and the flow and the tools and what are kind of highlights what goes into that encounter, that clinical encounter with a patient. So thank you so much. That's really terrific. And I'm going to remind folks that we are going to open it up for questions. If you have a question for a specific speaker, in the question box you can say this question is for Ann or this question is for Jim. Or if it's not really for anyone specific, just go ahead and enter it. We've got a couple of questions that have come in, but folks can use that question box that's over in the right-hand side. That's your panel. And we will go ahead and start with first question we have is, let's see, any thoughts about when you're having this conversation, and this could be for either of you, and maybe you both have some insight. When you're having this kind of conversation, how do you do that without, it's the intonation of the voice, making sure that you're not using language that shames people, and that can be really tricky, having that conversation. Any good tips on ways to bring this conversation up without shaming folks, without pointing, targeting specific people, or when patients thinking it's really just them that you're asking this to? Any thoughts about that?
I think it's really important to stress again that that we inform patients that the risk and self-monitoring strategies that we're recommending for them are done for all patients, so that the patient doesn't feel targeted, that they are informed that it's a part of the policy of the clinic, and that it is an attempt to help them best manage their pain in an evidence-based way, and that there is science behind the strategies that we're using. Again, for folks who haven't had motivational interviewing, I think it's really important, and I always recommend that professionals that are dealing with these patients have the whole course in motivational interviewing, because it's going to talk about non-confrontational approaches, how to ask open-ended questions, to how to ask questions that won't create resistance on the part of the patient, because we know that resistance is often a part of what happens when we ask people to change behavior. So I think it's really important in particular to have that training in order to minimize resistance.
Great. Well, thank you. I didn't know, Ann, if you had any other comments, any experience with lessons learned.
Well, I think when we're dealing with pain patients, they usually are in situations with a healthcare provider. A lot of times with a healthcare provider, they're going back to their primary care physician or to whoever has prescribed the opioid medication. So I think it's really very easy to bring up the conversation, especially when misusing substances is interfering with their health. So if a patient has health issues that may be being exacerbated because of misuse of prescription opioids, then I think that gives us an opportunity to really bring up the conversation in a way that that really is focusing on improving their health. So, so I think that's dealing with it in that way it makes it really easy in a healthcare setting.
Great. Thank you, Ann. A couple more questions are coming in. Folks, I encourage you to use your chat function, and I'm going to respond to a couple of folks as I want to get some clarification on make sure I get their question right. So I've sent a couple of folks some replies. So if you want to clarify a little bit, that'll help me make sure I get your question right and we get it answered. The next question I have is, do you find that by explaining what the scores on the screening tools, such as the SOAP, etc., skew subsequent scores? Because we know that patients know why you're asking and how you were using those numbers. So let me make sure I'm saying, yeah, does that make sense to you? And I'm trying to make sure I read this question right. And if the person who's typed in the question has any clarifying points for me, let me know. But it says, do you find that by explaining what the scores on the screening tool is, such as the SOAP, skew subsequent test scores because the patient knows what you're asking or why you're asking?
I think there's always a bit of a concern that the scores may be skewed a little bit, but overall, research has pretty much shown us that people generally are pretty honest when it comes to these screening tools, and if they're honest initially, and then we follow up with screening tools and explain to them what their scores are, there's a possibility that they may skew it a little bit because they want to continue taking those opioid medications. However, there's a lot of other indicators that we're looking at. It's not just the screening tool that we're looking at. We want their functional goals. We want to see that they're improving in a lot of different ways. So the screening tool is not the only tool, but I do think that people generally do answer those with a level of honesty, and if they are skewed, I think that the provider, the practitioner, can pick up on other clues to that.
Mm-hmm. And I know we've worked with some sites across the country who look at their data and they look to see what the scores are and what the rates of screening positive or the different levels based on levels of risk based on the tool. And it's interesting to see that there's a lot of participation. There's very low refusal to answering the questions. And when they look at baseline rates of identification prior to implementing screening routinely, they found that after doing that, identification rates went up significantly. And so, I often hear, well, if we're identifying more people than we were before, even if some patients may not be want to talk to us about it or may underreport, we're identifying more people who are reporting, and that gives us the opportunity to help those who are ready and want to talk about it. And sometimes screening in and of itself, even if the person perhaps didn't answer the questions honestly or accurately, that may be an intervention of itself. And so patients going back the next visit, maybe that moves them along that readiness to change, and they might be more inclined, if you were to rescreen later, to answer the question. So, but we have the same experience that most people have been sharing about their behavior, and it's provided an opportunity to really provide a brief intervention.
Right. And I think screening, just identifying and helping patients to understand where they are in comparison to other patients, and just seeing where they are on that level, on that screening tool, can help move them toward making behavior change. So just those little things that we can do to help raise awareness is really important, and screening in and of itself helps to raise awareness, whether they're honest on it or not. So,
exactly. I have another.
Tracy, I think it's really.
Oh, go ahead, Jim.
This is Jim. I think it's really important to point out that when we implement SBIRT, often we're dealing with patients who are at a low level of risk. They haven't crossed over into addiction. We know that individuals who have already crossed over into addiction will have less disclosure than patients who are at a low level of risk. We also know that patients generally are much more honest in terms of their disclosures with health professionals as opposed to behavioral health professionals.
Thank you. Thank you. We have a couple minutes left. I want to get another question in here. Make sure I get this right here. is it the documentation of the trained SBIRT representative that insulates the doctor from a claim of abandonment after discontinuing the prescription? And does that determination bars the patient from engaging in another management regimen? So let me repeat this to make sure I get this right and that you get to hear it more than once. Is it the documentation of the trained SBIRT representative that insulates the doctor from a claim of abandonment after discontinuing the prescription? And that's the first question. And that determination bars the patient from engaging with another pain management regimen.
Okay. Well, let me answer the second question first, because there's nothing that bars the patient from engaging in another regimen with another physician or another practitioner. The documentation does not, it's not aimed to protect the physician. It really is not. What we, in our documentation, we're really trying to improve functional goals with patients. And if functional goals, if the patient is not getting better, if they're not improving, then there's no point in continuing with regimens of opioids. And so, you know, this whole pain care movement is more to balance opioid risks with benefits. And each provider has to evaluate really whether the risks are exceeding the benefits and whether or not that provider is comfortable continuing to prescribe opioids, because if the risks exceed the benefits, then you know, it's the patient who's not going to have good outcomes. So, you know, it's not really about protecting the physician or the provider. It's about moving toward functional goals and, you know, balancing the risks with the benefits.
Thank you, Anne. Jim, I don't know if you had something else you wanted to add to that, or?
No, not really.
Okay, great. And then I have one last quick question, I think, is have you done this or have you used similar protocols working with pregnant women in an OB/GYN practice or setting who first come in with their first visit complaining of pain and wanting opioid meds? Have you used the same kind of protocol with that group as well?
I know we've used the SBIRT approach here in West Virginia with pregnant women, and it's worked very well in terms of reducing the risk for fetus who's exposed to substances, particularly in terms of use of opioids. I don't have any particular experience with that. Maybe Anne can comment on that.
Well, I think that we are really putting a lot of resources into working with pregnant moms, because it's, you know, it's such a problem when babies are being born addicted to opioids. But I think that we are doing it in a manner that doesn't just assess for risk for opioids, but for all substances. So, you know, I think it's more of, you know, an integrated approach with them, because fetus is exposed to any substance, whether it's opioids or alcohol or, you know, illicit drugs. You know, we're trying to prevent all of that. So I think it's more of an integrated thing, but most definitely we're doing much more with pregnant moms, because it is becoming such a problem with fetuses being addicted, you know, babies being addicted to opioids.
Mm-hmm. Well, great.
So I think SBIRT fits really well, you know, SBIRT for opioid risk, using the opioid risk tools is very important for pregnant moms.
That's great. Thank you very much. Thank you very much. Well, I see there are additional questions, but what we're going to do is we're going to close our webinar today with a few more last-minute thoughts. But what I would encourage folks to do, both Ann and Jim are very, very kind to share their email addresses. If you would like to certainly contact them directly to get some of your additional questions answered, they've been kind enough to do that. And I would also encourage folks to go to some of the links that they provided in their slide presentation today. That was very nice of them to let you just link directly to those tools you mentioned. Folks can also find more tools on prescription medication, misuse protocols, guidelines, working with pregnant women on the hospital SBIRT.webs.com website. There are webinars and protocols devoted to that and a range of other resources. So just to wrap up our presentation today, let me thank both Ann and Jim very much for sharing this terrific information, providing this these wonderful slides with lots of materials and references and experience that really shine through, that I think people can draw from in their own settings. And all the PowerPoints are available on the hospital SBIRT.webs.com website. There is a web address, as you can see at the bottom, that will take you directly there. You can access the CE quiz, which is also very important because I imagine folks want to take advantage of the free CEs today. And we'll be shortly, very soon, posting the archive version, an on-demand recording of this webinar, which you are encouraged to share with your colleagues, send out on your blogs and your newsletters, and let people know about it. The education is free for them as well. And we'll be following up with you, and in fact, Misty has already posted a link, a survey. This survey is very important to us continuing to bring you high-quality education and terrific speakers like we had today. This evaluation is really essential to maintaining our funding and demonstrating really the kinds of things that we want to do in the future, which is continue these excellent series on a variety of topics, including prescription medication misuse. So please answer that survey. That's really important to us. And next, we'll just remind folks to look for an email from Misty, so in case you don't have a moment to do that survey right now, she'll be following up with you. And remind you that we have this terrific webinar series, more to come around SBIRT and the treatment of tobacco, and also applying SBIRT in the context of depression, more medication abuse. We'll have more on tobacco use over the summer. So you can see we've got some themes going and trying to present a kind of a series on these hot topic issues. We've also done a hot topic issue around marijuana use that's already archived, and application of SBIRT to trauma and other concerns. And so we'll also be, later in the summer, be talking about integrated care and training integrative behavioral health and social work, and why integrated care in general. So please share this flyer, post it on your website, your blog, share it with colleagues. This is a downloadable flyer, and the education is free, and we're providing free CEs as well. So I'll wrap up by saying thank you very much for attending, and thanks for all of our sponsors, NADAC and the National SBIRT ATTC, the Hospital SBIRT, Big Initiative, and NORC at the University of Chicago. I look forward to having you all on future webinars, and thank you again to our speakers. Have a great day.
Thank you.